people use the term addiction very loosely, like I'm addicted to shopping, I'm addicted to Netflix, I'm addicted to porn. It's all ways in which people are saying, like, I'm doing something that I wish I was doing less of or not doing at all. Again, that's just the doorway into the conversation. I just don't think we have good language culturally to describe some of this. And so if this is what comes to my door, that's fine. Now I just want to understand, what is it that they are meaning by when they say I'm addicted to porn or I'm addicted to sex.
Why do so many people think they're addicted to sex when they might not be at all? In this episode, we step inside the lab to challenge one of the most widely accepted and misunderstood ideas in modern sexology, sex addiction. Together, we unpack the difference between distress and disorder, explore how shame and cultural narratives shape the way we interpret our desires, and examine what's actually driving out-of-control sexual behavior. Michael Vigorito is a licensed psychotherapist, ASEX certified sex therapist, author, and educator, specializing in compulsive sexual behavior, relationships, and sexual health. He is known for challenging traditional sex addiction frameworks and advocating for more nuanced, evidence-based, informed approaches to out-of-control sexual behavior. Michael Vigorito is the co-director of the Sexual Health Alliance Problem Sexual Behavior Advanced Certification for Professionals. This conversation with Michael discusses how we define what's normal, what's healthy, and who gets to decide that. If you get the feeling there's more to the story when it comes to sex addiction, this episode will give you a new lens to look through. So let's dive in. Welcome to Sexology Lab. Each week, we speak with the most compelling minds in modern sexology to ask the questions shaping the future of desire, connection, and human wellness. Let's dive in. Hello, everyone. Our guest today is Michael Vigorito. Welcome, Michael.
Well, thank you for the invitation to be here. I'm excited to talk to you.
We're so happy you're with us today. And I want to know, where in the world are you joining us from?
I am calling you from my DuPont Circle office in Washington, D.C.
Amazing. Now, Michael, I want to know, what's one thing people would be surprised to learn about you?
I just came back from Colombia to celebrate my husband graduating from his MBA program, and we got to do some pre-carnival events in Barranquilla, which was a lot of fun.
Amazing. That's so cool. Tell us your 30-second origin story. How did you get into sex therapy?
It's a great question. It started working in San Diego, my first job out of grad school, at an HIV mental health clinic. So right there, you're already talking about helping folks address their sexual health and also some of the risk factors for HIV or untreated mental illness, untreated substance use disorders. So I was getting great education there. And then within the clientele, there were folks who were concerned about sexual self-control. And so that got me started in wanting to focus specifically in sexual health, but also more prominently in working with men concerned about problematic and out of control sexual behavior.
And so did you start out like in a sex addiction space and then move away from that? Or were you just never there?
I was never there. I was working in an LGBT center that had a clinic within it. It was Ryan funded. So it was focusing on folks who were HIV positive or at risk for HIV. Within the clinic, people were coming to me self-identifying as being addicted to sex. So that's when I started going to literature because I was so green. I didn't know what they were talking about. And so I started looking into what the literature was saying. And in the consumer literature side of the house, like that was predominantly all sex addiction focused. And when I was reading it, I was just like, if I apply this to the folks that are coming to see me, I'm going to be pathologizing people who are struggling with coming out. A lot of the symptoms of sex addiction were about secrets and shame. And I was like, yeah, this is a developmental issue as someone's coming out. So I'm not going to put on the top of their problems to identify as a sex addiction as the only way to be able to address their issues. So I kept going. And that's when I discovered the literature around sexual health and self-regulation and motivational interviewing. And I was like, wait, there are other ways to look at this and to address this issue outside of sex addiction.
All right. I want to talk to you briefly about current events. Specifically regarding the recent law changes around conversion therapy. If somebody's listening to this and they're like, I've heard the term conversion therapy, but I don't really know what it is. Could you describe to us what that is?
The Supreme Court recently ruled against bans on conversion therapy. And for millions of LGBTQ plus folks who live in the United States, it's not just a legal loss, right? It's a loss of consumer protections. What is conversion therapy, right? These are attempts to change someone's sexual orientation or gender identity. And it's based on a discredited notion that diversity of sexual orientation and gender is a mental illness that needs to be fixed. Major medical and psychiatric and psychological associations agree that one, it doesn't work, and two, it's harmful. Some of the techniques in conversion therapy range from talk therapy to deeply disturbing methods like forced medication, aversion therapy and electrocution, verbal abuse, exorcism in some cases, right? The UN describes this technique as cruel, inhumane, degrading, and in some severe cases, torture. Now, these bans weren't just civil rights protections, right? They were patient protections. They were stopping licensed providers from selling a harmful, discredited practice. And without them, there's less accountability for what happens in psychotherapy offices. And there are particular groups of people who are more vulnerable to the harms of conversion therapy, such as youth who can't always consent to or refuse the care that they receive, people who live in rural communities where there might be fewer provider options or fewer options of folks who take their insurance, or anyone who's in crisis, right, who is walking into a psychotherapy office assuming that provider is going to follow evidence-based and ethical standards, but they don't. And conversion therapy has been linked to depression, PTSD, higher rates of suicide attempts, and anxiety. Youth are 3 times more likely to experience severe depression if they are exposed to conversion therapy techniques. This ruling doesn't change the science. It doesn't change the ethical standards for social workers, marriage family therapists, counselors, psychologists, psychiatrists. It just removes a layer of protection for the consumer. Patients deserve to have providers who follow the highest standards of care, which support identity development, which builds coping skills, which helps clients address the impact of stigma and discrimination. So it's important as providers that we support LGBTQ plus mental health resources, that we educate ourselves on the highest standards of care for LGBTQ folks, and we communicate how we work with this population so people can find us.
Do you have any advice for other sexual health professionals during this time? Like, how can we support each other? How can we support the general public?
I think it's around, one, continuing to network and connect yourself with other providers who don't provide conversion therapy. So when you are receiving referrals, you know who to refer to. And it also might be helpful to be more out and open about the type of work that you provide so people can find you.
That's good advice. Now, I want to switch gears a little bit, and I want to talk about something that I see a lot in the media. I want to talk about sex addiction. So when somebody says, I think I'm addicted to sex, how often are they actually right?
I say never, but that's not what I say to them when they come and see me. I understand what they're saying. They're using this as a metaphor to tell me that they feel out of control. I don't want to lose my curiosity about what it is that they're trying to send to me. So even if they say that, they come to me to say like, hey, I think I'm addicted to sex. I'm like, okay, tell me how you came to that conclusion, or what is it that you're trying to say with that term? Or tell me how you've tried to redirect your behavior, or tell me what is concerning to you about your sexual, right? Like I use that as the start of the conversation. I don't necessarily come in and say, well, you're wrong. This is what the research says, right? I just want to understand what their internal experience is. So I just use that as a springboard to get curious about what is it about that phrase or that term that feels like it best describes your internal world. And then we can go from there.
Yeah. And what have you found where this belief comes from for most people? Have you found like a common thread?
I don't think it's a far stretch that people reach for this term, because it is what people use in common vernacular to describe a behavior that they engage in despite the consequences. People use the term addiction very loosely, like I'm addicted to shopping, I'm addicted to Netflix, I'm addicted to porn. It's all ways in which people are saying like I'm doing something that I wish I was doing less of or not doing at all. Again, that's just the doorway into the conversation. I just don't think we have good language culturally to describe some of this. And so if this is what comes to my door, that's fine. Now I just want to understand what is it that they are meaning by when they say I'm addicted to porn or I'm addicted to sex.
And sometimes when people have these behaviors that they want to change, they don't have the language for that. Maybe they hear sex addiction in the media, or they hear the term addict used a lot, and that's how they're feeling. But in our field, as we're progressing, we're using terms like out of control sexual behavior and problem sexual behavior. How do you define out of control sexual behavior versus the term sex addiction?
Sex addiction was one of the proposed diagnoses, so it has a whole set of diagnostic criteria. Out of control sexual behavior is not meant to be a phrase to substitute for a diagnosis, right? It's just meant to be a description of a person's internal experience. So when I'm using the term out of control sexual behavior, what I'm saying is that someone feels like their sexual urges, thoughts, or behaviors feels out of control. It's almost like a placeholder So I'm not inserting diagnostic sounding language in order to describe something. Because if I say something is addictive, right, that has this whole criteria. If I say that I'm sexually compulsive, we know compulsivity is a symptom of an anxiety disorder, right? It's a behavior that someone engages in order to relieve their anxiety. So if they're using it as a metaphor, I'm as a clinician, I'm like, that has a particular definition, right? And now we're not talking about the same thing, because a person might be engaging in sex to relieve some of their anxiety, but they might be engaging in sex for other reasons. So I use this phrase, out of control sexual behavior, as I said, as kind of as a placeholder, so I can kind of describe that internal experience. So then we can get curious about all the factors that can contribute to why someone might feel out of control, and not make an assumption that we understand the etiology right from the beginning.
What do you think is the biggest misunderstanding that people generally have about sex addiction?
I want to answer this more about how I was feeling when I was answering the initial questions, right? Because when you asked me about how many people actually have a sex addiction, I'm like, 0.
Yeah.
I worry that I am dismissing people's pain, right, and their distress about their sexual behavior when I'm saying. But what I'm trying to communicate to folks is that I want to be able to conceptualize the factors or why someone is having trouble regulating their sexual behavior, so I can develop a treatment plan that's effective, right? So when I'm saying it's not sex addiction, I don't want people to think that I'm saying this is not a problem. I don't want to feel like I'm minimizing this for them. What I'm trying to do is like, okay, I hear that you are pain and distress, and this is the narrative that you're coming to me. It's like, okay, let's evaluate this narrative, because I want to create a treatment plan that's going to be effective for you, right? So when I say the conceptualization or the treatment plan is not going to be based on sex addiction, it's not because I don't think they have a problem. It's just because that really doesn't have much explanatory power. And it's hard for me to develop a treatment plan based on a metaphor that someone is using about their internal experience.
That totally makes sense. And what's wrong with the sex addiction model? Because there's sex addiction treatment centers, certified sex addiction therapists. What's wrong with using that model?
Well, there's a couple things. One, there isn't really a standardized definition of addiction, right? Just multidisciplinary, right? And then we also look at, when we apply it to sex addiction, we have all these different definitions. So it's really hard to agree on what is that we're talking about just in general when we're saying sex addiction. But what we find is that oftentimes people identify symptoms of a sex addiction as just the sexual behavior is unconventional. So people might be engaging in some type of kink, and they label that act as being unhealthy and immoral, and that is the symptom of a sex addiction. Or people who might have some type of queer sexual orientation, right? That too could be labeled as a sex addiction, right? Some of the cutoff scores for some of these measures, right, are a bit subjective. I remember they were getting debate. I was like, all right, is 5 orgasms a week healthy, but 7 orgasms a week is unhealthy? So therefore, if you're having 7 orgasms, like these are the type of things that people are kind of wrestling with in these models. So it's like, no. We need to find a different way so we're not overly pathologizing diverse sexual experiences, right? The other piece is like, because we're using this metaphor, we're taking an etiology from substance use disorders and then applying it to sex, right? And that's kind of the leap in logic that hasn't been established in the research, but it comes with it some other notions around addictions that people carry, right? Like it's a progressive disease, right? So you're going to start smoking pot and then you're going to end up injecting meth, right? That this is just going to progress into this more destructive behavior, right? Or you start drinking alcohol a bit over here, and by the end, you're kind of binge drinking alcohol here.
Right.
So then what is the equivalent for sex, right? It's like, all right, so you're going to start engaging this sex over here, and then you're going to devolve into X, right? That doesn't necessarily follow through, or it doesn't pan out typically. But then we get into this idea of like degenerative nature of that would lead to things like, I'm going to start looking at child sexual abuse material. I'm going to start being a sex offender. And then people get extremely scared. And then they come into me, it's like, oh my God, I got the sex addiction. I've got a treatment. I'm always being treatment. Whoa.
Yeah.
Slow down. Let's just talk about what's happening. It traffics some of these assumptions and this degeneracy model into a person's self-concept and their identity of themselves as being addicted, that I don't find to be helpful, right? It's just kind of all these shame-based narratives that I'm trying to pull out. Ultimately, the goal, right, is around integration. I want someone to be able to express themselves in a way that feels both pleasurable and responsible. Much of the addiction model is around abstinence, right? So already there's kind of this tension between what I'm hoping for my client, which is around integration, versus the kind of the recommended treatment, which is around abstinence.
It's like their mind goes to the worst possible outcome. That's not how that trajectory goes.
it doesn't. And if that was, and then it's like, yes, but we're going to create boundaries and limits, and that's not about integration, right? Most people are coming in who are concerned about having a porn addiction, for say, like don't have any non-consensual elements in their behavior. And because they're having trouble regulating, that's not what's going to happen. We can have a conversation about folks who do have non-consensual elements in their erotic orientation, the help that they can get. But even those folks, the help that they can get is not sex addiction treatment, right? They need to be seen by someone who specializes in working with non-consensual sex. Those folks also don't apply a sex addiction model to help those patients who are coming in concerned about sexual offense.
The problem with the abstinence model is injecting meth is not a healthy part of everyday life in a well-rounded person, but having a happy, healthy sex life that's part of a healthy lifestyle. And so saying that you're just not going to have sex at all is not going to help somebody feel happy and fulfilled.
No, what I often say is like, no one wants to create a goal to have a boring sexual health plan. They're not going to be motivated to do it. Yeah. So like I create a sexual health plan. It's just like, I'm only going to be masturbating once a month, looking at this porn that is really not that interesting to me, and having sex in this particular way that's also not. No one's going to want to do that. The tension for all providers here is we're trying to find a way for our clients to have pleasurable sex in a way that feels responsible for them. And there is tension there, but to me, we have to find ways to have both of those concepts in the room when we're working with our clients.
And I want to go back to the label. So labeling somebody a sex addict. What are some more problems with that label? Either a clinician labeling somebody a sex addict or somebody labeling themselves a sex addict.
Let me just start with the clinician first. I don't recommend labeling clients with whatever disorder that I'm treating them. When I work with someone with an eating disorder, I'm not saying that you're bulimic. If I'm working with someone with schizophrenia, I'm not saying you're schizophrenic. That does not define the totality of who they are. You know, this is kind of some of the shame-based narratives that I recommend providers to avoid. So I would never talk to my clients as like, oh, you're an addict or you're a sex addict. And it feels a bit paternalistic and it feels dehumanizing. So that's also part of the reason I use different language when I'm talking about they feel like they're sexually out of control or they're engaging in some sexual behavior problems that they're trying to address. You know, it's all person-centered language. Clients, on the other hand, like I want to meet them where they're at. So if they are self-identifying as a sex addict, I'm not going to try to move in to change that identity, right? Because they might not be ready to just yet. I just want to get curious again about how they came to that decision that they are a sex addict. What is it about that label that is congruent for them, right? Is there any incongruence for them? Because that would maybe be the start of evaluating their language to something that's less pathologizing or more person-centered. So with my clients, I don't want to recreate the paternalism of the sex addiction model, right? Like I want to be open and curious and understand them a little bit more. And then when I feel like they're ready, to invite them to consider other ways of thinking about themselves that hopefully isn't as shaming or kind of centering around a disorder. They are humans. They are more than that. They are multidimensional. So I want to take that more humanistic approach with them.
Are you curious about sexology? Do you want to further integrate sexology into your work or your life? Well, friends, then we've got something just for you. It's called the Sexology Practice Guide, and it walks you through the ways this shows up in your work, in your life, and guides you through working within your scope, incorporating intimacy and sexual health into your work without starting over. Download this short, practical guide at sexologylab.com/guide. That's sexologylab.com/guide. And while you're here, make sure to subscribe and share. And now, back to the show. Now, one thing I've noticed is the sex addiction label in the media. I see it being used sometimes to, should I say, excuse bad behavior, like choosing to cheat on their spouse. Their spouse catches them looking at porn, and it's like, well, I'm an addict. What do you think about the media using sex addiction to excuse certain behaviors?
It's actually a bit congruent with the model, right? There's a way in which sex addiction ideology around it externalizes responsibility. I did this because I'm an addict, right?
Yeah.
I hear that language regularly. And part of the reason why I might invite my client to evaluate that language is because I want them to think about their own agency and their own autonomy. They are making choices here, right? And so if they just do the shortcut, oh, I did this because I'm an addict, we are missing the opportunities to understand how they were directing their behavior, the choices that they were making, the function of this behavior. in a way, the media is just reinforcing that perspective that's kind of embedded in the sex addiction model that does not encourage folks to understand their own agency in the behaviors that they're concerned about. In that sense, I'm not surprised. It can be a bit frustrating. Most of my clients know that I work from a motivational perspective. So if they use some of that language that jumps ahead or skips over, like one of the favorite ones I have is like, they'll be talking, it's like, and then all of a sudden I was like, there was a lot of choices and time between your, driving down the street. And then all of a sudden I'm at this sex club. And you're like, cool. Okay, walk me through what happened.
Yeah.
Slow those moments down. And that's all to bring the spotlight of their attention to their agency, right?
Yeah.
And it might have felt like all of a sudden, and that is curious, that is interesting. There might have been a bit of a habit here that they were just kind of engaging in. It's kind of like all of a sudden I found myself at work, right? But no, I was driving there. It's a habit. So if that is what they tell me, I was like, all right, well, let's go back. And they're like, I don't really remember. I was like, okay, that's fine. Well, the next time I want you to just check in with yourself. How are you feeling? What are you thinking? What is happening? Don't change your behavior. Just check in with your body, right? Because I want to bring that attention in that moment where they might not have been paying attention before. So again, just to raise their agency. But if I just let them say, it was like, well, my addict brain took over. I was like, see, that's an example of externalization. And we miss opportunities to understand the choices that they're making or raise their awareness about what it is that they were doing.
Now, when somebody labels themselves as a sex addict or comes in because they have sex addiction issues, how big of a role does shame play in that?
It's humongous. Humongous. I mean, if we think about some of the research that talks about why people might identify as a sex or porn addict, right? One of the biggest things is this concept called moral incongruence, that they're engaging in behavior that they believe is morally wrong for them. And what is the emotional consequence of that? It's shame. So they may like something that they don't think they should like, or they're engaging in sexual behavior that they think is morally wrong based on oftentimes their religious value system, right? So they have this idea of how they should be sexually, but what turns them on or the behavior they're engaged in contradicts that. And what do we know about shame? The definition of shame that I like is feeling seen in an extremely diminished way. You can see that with children. This is a primitive emotion. Like when kids get embarrassed or feel shame, what do? They hide their face, right? Or they hide behind their parent's leg, right?
Yeah.
Adult defenses are a little more sophisticated. We use figurative language. We don't talk about it. We just don't disclose it. We create compartmentalization defenses. And so we don't have to talk about it. We kind of create these splits. So those are some of the patterns or defenses that create some of these problems, right? So if I feel ashamed of some of the sex that I enjoy, then I can hide that. And that is antithetical to intimacy, right? Intimacy is all about being seen, but shame is about not being seen. And so these are where some of the problems come up, right? And sometimes it's easier to identify as having a sex addiction than it is to reveal some of the things that turn me on. So if I'm in a relationship and, someone, put this in quotes, catches me watching porn, I can just say, I can externalize it. Or like, no, this is a symptom of my sex addiction. I don't have to own this. This is not something I want. And we're going to treat it and we're going to get rid of it. Versus this is something that is really embarrassing to me. I was hiding it because I don't want this about me. Is there a way that we can talk about this in a way that maybe we can I can integrate that into how I understand myself, integrate this into the relationship? You can see how much harder that conversation is. If this provider says I can get rid of it, then I'm just going to go there. So I don't have to have these uncomfortable conversations. I don't have to accept this about me and then I'm be cured, I'll be done. It's interesting that we started this conversation with conversion therapy, because what I tell folks is that scenario that I just talked about is a sideways attempt at conversion therapy. So if I am concerned about my sexual expression and I feel ashamed about it, I don't want to be turned on by this particular thing, and then I label that as a sex addiction and I want to treat it, what we're trying to do is they're trying to excise that part of them. They're trying to cure themselves of that kink or cure themselves of whatever it is that turns them on that they are shameful for, right? And that sex addiction treatment just reinforces the shame-based narratives they have about this thing. So again, going back to the earlier concept of what I was talking about, like my work is about integration, right? Not about abstinence. If someone has some type of unconventional sexual interest that they've been hiding and then they've been masturbating by themselves and they label that as a sex addiction, then the logical extension of that is if I treat my sex addiction, then I can extinguish this part of my erotic orientation. What is that? That is conversion therapy.
So you just used the term erotic orientation. So for anybody listening who's not familiar with that term, could you tell us what that is?
Yeah. Erotic orientation, similar to sexual orientation, right? So sexual orientation is to whom I'm turned on by, right? To whom I'm attracted to. Erotic orientation is more like the what? how am I turned on, right? The themes, the concepts. Sexual orientation is usually around I'm attracted to men in masculinity or women in femininity. Eroticism could be like I'm turned on more by themes of submissiveness, themes of dominance. I like the wrestling for power in the situation or overcoming ambivalence, right? It is how someone gets turned on. And similar to sexual orientation, right? This is their internal experience. It's typically immutable, right? It's not something that we can change. It is something similar to our sexual orientation that the person discovers. And they're usually discovering at a point when they already have ideas about what should turn me on. And when they kind of figure out the signal from the noise of what actually does turn me on, there might be a conflict between the two, right? So there's a whole kind of coming out process that I think is similar to sexual orientation for someone's erotic orientation. So if people understand that process, then it's actually very helpful for my clients who are coming in with unconventional turn-ons. I explain to them the concept of erotic identity development, right? Where someone identifies what turns them on, then they put labels and words to it, and then they kind of fold that into how they understand themselves. They know that this is going to be persistent and consistent. It may evolve over time, but it's likely going to stay with you. And then you start communicating it to others. You start kind of coming out, and then you start creating relationships that include this, right? And again, the concept of integration is in multiple parts of how I work. Right?
Yeah, absolutely. Because I could imagine that being very scary for a lot of people if you grew up in like a very cultural, conservative, religious like upbringing. And then all of a sudden you realize like you're into getting handcuffed to the bed. And you're not into, just regular missionary sex is like what you're supposed to do to only get pregnant or whatever that may be. And you're like, oh my gosh, I'm a weirdo. I must be a sex addict. And you start panicking.
Yeah, I think panic is a good word. I was hearing some of my clients who talk about this. And for that example in particular, it's like the person who loves me is not supposed to handcuff me. That is not a loving act, right? So you can see how you don't even have to have a deeply religious or conservative background to see how sometimes it just contradicts with our values around romantic relationship. So it can create an internal conflict for the person. And then now they're worried about, oh my God, if I reveal this, my partner is going to reject me because their thing is like the person I love wants me to handcuff them and wants me to swaddle them. Like hitting is not a loving act. And so they hide it. It takes real courage and vulnerability to, one, accept this part of their own erotic orientation, and then to communicate, hoping it's going to be received in a way that's loving and honorable. Sometimes people will come in because their partner had a negative reaction. The partner was condemning, or it's like, I'm not going to do that. That is a form of, a sickness or mental illness. Then you go get help for that. And they might come to see me as like, can you scoop this? I have like this psychological melon baller. I'm just going to carve this part out of you. And then you're going to go on and enjoy conventional, traditional missionary sex with your spouse. And I have to disappoint people up front. In my opinion, it's a part of the informed consent. There are limits to what I can do in psychotherapy.
Right.
And I cannot change your erotic orientation. If I attempt to change, one, it would be ineffective, and two, it'll likely be harmful because going back, will reinforce some of those shame-based narratives that you have about yourself. My hope and goal for you is around integration.
And so we're going to stop calling it sex addiction. And what framework actually helps?
The model that I developed, right, was just to create a protocol that can capture all the ways in which sex can become dysregulated, right? So any model needs to be multifactorial, right? To understand that oftentimes people will have concerns about out of control sexual behavior because it's a symptom of an untreated or undertreated psychiatric condition. They're coming in because they are depressed and they're using sex as a way to manage their mood, or their mood is so depressed that they are kind of isolating. And one of the things that they're doing when they're isolating is just masturbating or looking at porn online, right? Or it could be an expression of ADHD or a way that they are regulating their anxiety. Like any good psychotherapist, you have to screen for any untreated or undertreated psychiatric conditions because that could address some of the sexual symptoms. It has to take a look at people's beliefs or the moral incongruence around what they're doing, right? So they have some rigid standards about what sex should be that they are not meeting, that is creating internal conflicts, right? Because it is not a benign event to think that what I am doing is sinful or might risk my marriage or my religious community, right? These are true emotional consequences. Or it might be a values conflict within the marriage. They might be defining fidelity in a particular way that is difficult for a client to maintain. I mean, I don't know how many clients I have that come in under this idea of monogamy that I call fidelity of thought, that my partner shall only have any type of sexual experience or pleasure with me as their spouse. So partner sex and masturbation should only be
Yeah.
fantasizing about me. So fantasizing about other people is considered infidelity. And the
Mm.
fact that you can't maintain that is a symptom of an addiction, and you should go get help. So a protocol or a treatment modality needs to be able to assess all the ways in which sex can feel out of control for them. We talked
Yeah.
about one earlier around one's erotic orientation. So how do they relate to the fact that they have an unconventional turn on, or they have an internal conflict about the type of sex they like? The narrative they have is that this is either unhealthy or sinful or bad in some way, threatens my relationship. And so they are defending against understanding it, accepting it, integrating it into their lives. And that split will create symptoms of depression, symptoms of anxiety, right? Because you have this adversarial relationship with yourself that you are constantly defending against. Those are really significant thoughts that they're having that have emotional consequences that are painful. So they're coming in treatment because they are depressed. Why are they depressed? It's because they think they're going to die alone, right? So like,
Right.
okay, so can we address that shame-based narrative, right? So the word that I was using earlier, if I had to describe my treatment approach with one word, is curiosity.
Yeah.
We have to be able to be curious about all these different ways that people can feel out of control sexually, from an untreated mental health condition to values conflicts in their relationship to erotic identity development problems. That's one of the reasons why the sex addiction model doesn't work for me, because it's so singular. It doesn't capture the diversity of the human experience. So
Yeah.
that's why I wrote this book, was that there's another approach here that can hopefully be more humanistic and person-centered, and it can create an individualized treatment plan for the issues that the client is coming in to see you that they've just labeled sex addiction.
I love that answer. That was very thorough. Thank you, Michael. Okay, we talked about all the ways that somebody coming in saying I'm a sex addict is not really a problem. Now, when is it a problem? Like, when is it something you're concerned about?
When you have an internal conflict about what's going on. I work from a motivational interviewing perspective, right? And when I'm teaching on doing an assessment, the first screening criteria that I encourage clinicians to evaluate is motivation for change. Why are they coming to see me? I want to make sure it's their motivation. It's not their spouse's. Like, I'm coming in because my spouse thinks I'm a porn addict. I'm like, that doesn't really tell me anything about what is going to motivate you for change, right? What is it about your sexual behavior that is creating conflict? So the conflicts can come externally, right? Which often happens, like a partner discovers that they weren't honoring their sexual agreements in the marriage, or they were engaging in some type of FinDom experience secretively, and the cost of that has been problematic, or they've been paying for sex and maybe they got arrested, or the cost of that has been creating some problems for them. So sometimes what's coming in is that they've experienced a negative consequence to their behavior. And that's the light bulb moment going, okay, this has been difficult for me, or my behavior is creating some problems in my life. Let me go address it. Or oftentimes what I see is like they receive one consequence and they're like, all right, I'm going to try to address this on my own. I'm going to right the ship. And they try to right the ship and they keep failing. So it's like, okay, I need some help on this, right? So they'll reach out to me and saying, yeah, I got arrested over here, but also got this DOI over here. And then my spouse discovered this over here. It's like, so the consequences started to build, that we're starting to break through from their defenses that there was a problem here. Much of the time that people come to see me is because of some of those external consequences, some of the internal ones, right? That could just be around the psychological consequence of understanding that what turns them on is not what they think should turn them on, or they're struggling with this values conflict in their marriage and their communication is just broken down, right? So they're coming into seems like, how do I do this? How am I having these conversations with her? How can I improve this? Or should I address these behaviors solo without involving them, right? So there's some things that they want to think through. How I work is understanding their self discrepancies or their internal conflicts, because that friction, that tension, that's the energy for change.
How often do people come to you who are actually committing crimes? So raping somebody or abusing children?
Occasionally, but enough that I tell folks who want to work in this space that you need to be prepared to answer this question. Are you trained in working with non-consensual sex? Is this an area that you want to work in? It's okay if it's not. I'm quite the advocate of providers specializing and knowing what's outside of their specialty. So I work with consensual sexual problems. I don't work with non-consensual sex. So I made that decision. But I know that in this umbrella of sex addiction, people will be coming in for help regarding non-consensual sex acts. So when someone comes to see me and they're like addicted to porn, like, okay, what is it that you're looking at, right? So as I mentioned, sexual conversations happen in the details. And they're like, well, I'm just looking at people having sex. I want to know more. Are there non-consensual elements of what it is that you're looking at? Is everyone of the age of consent? Is everyone consenting to be recorded, or was this filmed in a bathroom without people's consent? And then usually when people hear that question, something clicks and they're like, oh, no. This is professionally produced porn. Everyone's age is verified. That is not an interest or desire of mine, not anything I'm engaging with. Other people who I hear that is like, well, yeah, I'm actually coming in. This call just happened. It's because the FBI raided my home and took my equipment. My attorney recommended that I seek treatment. And I applaud them. I was like, yes, I think you need, I think you would benefit from care. I want to make sure I get you to the right provider because that is not my area. So if you're going to work in this space, it's important that you befriend the non-consensual treatment providers that are in your area, that are licensed in your jurisdiction. So I have a couple of folks that I refer to when people come in to see me for non-consensual sex acts. Are people engaging in criminal behavior? Non-consensual sex is not the only type of criminal behavior. Paying for sex is illegal, right? Engaging in sexualized drug use is illegal, particularly if they're using drugs that are illegal, like meth or G or Molly. Criminality is not the clinical distinction that I encourage my providers and trainees to make. It's non-consensual. That to me is the clinical distinction that will determine a course of action. So if they're coming in for criminality, I can still work with sexual behaviors that in some jurisdictions are criminal. I have clients who are concerned about paying for sex, right? That's a criminal act. But if they're engaging in non-consensual act, that is a different behavior that requires specialized treatment, and I want to get them to the care that's going to be most effective for them.
You do a lot of education with Sexual Health Alliance, and so you are the co-director of the Advanced Certification in Problem Sexual Behavior, and you also teach online weekend educational events with us. So why is it important for clinicians to learn more about out-of-control sexual behavior?
Selfishly, I just want more OCSB groups out in the world. Like I'm a group therapist as well. And I primarily work with men, right? So these are ostensibly men's groups. And I think men need more spaces to connect with other men, to talk about sexual health and responsibility. I think that's such an important thing for men in particular in society as a whole. So I'm hoping and I'm trying to attract more people. I really appreciate Shaw and they're giving me this opportunity to entice people to become group therapists and working with sexual health. For the folks who don't want to specialize in working in out of control sexual behavior, I think these trainings can be so important because people are going to be coming to you with sexual behavior problems. And I think it's going to be helpful for them to be able to think critically about how to address this, to not be caught up in some of the cultural narratives, to just assume that someone says that I'm a sex addict, that they're like, oh, okay, let's get you to sex addiction treatment. I want people to be able to slow those moments down and to think critically and to understand how to evaluate that narrative with their clients. And if you determine that they might benefit from someone who works in out of control sexual behavior that is not you, then this can facilitate that referral. I also think is important for couples. This concept is often used in the power struggling that is occurring when they're wrestling with their values about their sexual agreements or the type of sex that they want to have, or what is pleasurable sex and what is okay with pleasurable sex. And sometimes it'll be lobbed in that, well, you're just a sex addict and that then just derails the conversation. So I want be able to hold space for couples to have these conversations when that concept comes in, so they are not identifying that one person in the relationship as the patient, that they have this untreated sex addiction. If the details of problem sexual behavior make you a bit uncomfortable, right, you're just going to avoid these conversations. So these trainings, I think, will help you be able to lean in.
All right. Well, I want to close things out with a Michael Vigorito lightning round. So these are some fun questions for you. So what is the last book you read that you thought was really incredible?
The book I'm reading now is Orbital, which is a fascinating book about one day on the International Space Station that a group of astronauts and cosmonauts have as they orbit the Earth like 30 times in a day or something ridiculous. It's fiction, but highly researched.
What is one place you want to travel to?
So we've been traveling throughout Colombia, and it's such an amazing country. I have yet to be on their west coast in Cali and to see that. So I'm looking forward to that adventure. And also in the east, where there's a lot of kind of outdoor experiences like hiking and kayaking in the Andes. So there's a region in the east of Colombia that I'm excited to go to.
What is something you're currently obsessed with?
I'm obsessed with making like the perfect old fashioned. I am on an old fashioned kick at home.
Last lightning round question. What's your favorite way to relax at the end of the day?
I'm still newly married. So like Coming home to my husband and just snuggling with him has been a real gift.
That's a perfect answer. I love that. All right. Now, I like to leave these interviews with a message for the next generation. So, talking to our Gen Zs, our Gen Alphas, what's one important message you want to leave with them about sexual health?
Let's find a mentor. It is such an important part of my development. I find that having elders in the field have such great wisdom. And if you're like me, who kind of runs anxious, like it's always wonderful to have someone who can create the space for you to talk about your concerns and then have that experience that I respect and trust to be able to help us think through some of these issues. So yeah, find a mentor that you respect, that you trust. It'll be pivotal in your career.
I love that. That's great advice. All right. Well, thank you so much for being with us today, Michael.
Thank you so much for this. This was a lot of fun.
All right. Bye, everyone. Don't forget to subscribe on YouTube, Spotify, Apple, or wherever you listen. Links are in the description below.